debate, the final one, where we talk about if there is a suspicious topography, would you leave it alone or would you go ahead and do a procedure like ICL? So Manpreet will talk about leaving it alone.
Hello, I'm Dr. Manpreet. I'm Assistant Professor, Cornea Cataract and Refractive Surgery Services, API Center for Ophthalmic Sciences, New Delhi. So the topic is suspicious topography, to leave it alone, and there are no financial disclosures. The topic is to leave it alone versus ICL, but it is to leave it alone. So we often come, while screening for refractive patients, we come across suspicious topographies. We all know these parameters, so I won't go into these, the at-risk corneas. So sometimes you see central islands, irregular tongue-shaped extensions, displacement of the thinnest apex, and you decide abnormal Bellin ambrosio display, and you decide that you're not going to go in for a corneal ablative procedure straight away. So what do you do at that point of time? Leave it alone or ICL? So a lot of ICL bashing has already been done over the past few debates. So I'll be kinder to my opponent. And as I said to him earlier, I do believe in the surgery. So ICL is a very good option for indicated cases. The question here is not if it is safe, efficacious. We all know the end-off rates, cataract rates have come down significantly. And even though it's an intraocular procedure, it's a wonderful procedure. The question here, what I'll reframe is leave it alone for the time being. The question is not whether you can do an ICL or not. At that point, when you have a suspicious topography, none of us in practice are going to send back the patient and say, come back after 1 year or so. The immediate mentality is that you have to go in now. If corneal ablation is out of the question, do you wait or do you go for an ICL at that point of time? So that is what the debate is about. And for that, I'm a strong proponent of leave it alone. So phakic is for refractive and therapeutic procedures. So be very clear, what we are talking about here is not therapeutic, it's refractive. So the expectations change. The predictability, safety, efficacy parameters that you require are much more stringent that you would require for any therapeutic purposes. For keratoconus, for instance, which a suspicious topography may uncover in future, ICL is an indication. So that is not the question. That is a therapeutic indication. For a refractive indication, a refractive patient who wants to see 20 by 20 by 20 with optimal visual quality, is it an indication? No. So the cardinal rule of patient selection for refractive surgery, the one which we are taught when we start doing refractive surgery, is document refractive stability. So there my debate starts and ends. If you have a suspicious topography, you have to wait. You have to document stability. If it's stable, do whatever it takes to make the patient happy. Just a case example, a 25-year-old male, you may say that keratoconus is progressing in 10 to 20s. When a patient comes at 25, it's already stable. Even if it's a formicrustic keratoconus, go ahead with ICL now. Why wait for 6 months? So this is the topography of one of my own patients in December 22 versus March 23. And there is a change in topographic axis, the amount of astigmatism. So a lot of these patients, when they are planned for ICL, they'll be toric ICLs. And the outcomes will depend upon the axis and the astigmatism both. So if they're not stable, if they're variable, then you will not have optimal outcomes. So as you can see, the steep axis, astigmatism, the maximum K, everything changed over a span of 3 months only. Then optimal outcomes in phakic depend on adequate vault. In fact, phakic exchanges and explants are still required. And we have seen that explant related for vault related complications are decreasing, but then there are other complications as well which have been covered earlier. But then vault depends on adequate sizing. Sizing depends on white to white and anterior chamber depth, aqueous depth. These in even normal patients is so difficult to predict accurately. Even now we haven't tackled this holy grail. So in cases of ectasia or maybe a formipruste, are we going to be that accurate? I don't think so. Then at the end of the day, phakic intraocular implantation is an intraocular procedure. One of our cases that developed an endophthalmitis, we had a successful outcome. See, when we are counseling for cataract surgery, we say, okay, there is this percent risk of endo, it's fair enough. When you're counseling for refractive surgery, what I tell my patients is, there may be a 1 in 10,000 risk. If you are that 1 in 10,000, it matters to you because it's a cosmetic procedure, not a therapeutic one. So when you look at the world through rose-colored glasses, red flags are harder to be seen. So ICL, at that point of time, no, thank you.
Somebody has to help me with this. Thank you. Right. Good afternoon, everybody. I think it's a wonderful experience to be speaking in a cruise for the first time. And Dr. Manpreet is a faculty name, so she can afford to leave them alone. I will not leave them alone. I would rather do an ICL and then leave them alone. Right. So basically, if a patient has myopia, there are three. I mean, as we all know, we have three different ways of treating myopia. One is to change the corneal power, one is to change the power of the lens, and the third is to introduce a new refractive surface, which is an IOL, which does not interfere with the corneal curvatures at all. So basically, for introducing a phakic IOL, the inclusion criteria would be looking at the AC depth, the endothelial profile, iris shape, and the pupillary size also. So an anterior segment OCT is of immense importance, as the company says that, and if the AC depth is more than 2.8, then why not? The white to white is extremely important. There is a difference between white to white, angle to angle, and sulcus to sulcus. The white to white is what we generally consider in the clinical practice. Endothelial cell counts I generally measure before surgery, after 3 months, and after a year also, because these endothelial cell counts generally show a decline, and I think it should be maintained for almost the count should be regulated for almost a year. Size does matter. A short ICL would decenter, there would be a small vault. A long ICL, there would be an excessive vaulting. And if there is no vault, then there can be chances of a subcapsular cataract. Well, there's a concept of bioptics where we would first implant an ICL, and then, if there is a residual correction, then we can fine tune it with an excimer ablation also. Nowadays, with the advent of PRK extra, even in cases of suspicious topography, you could first go ahead with the toric ICL, and then after the refraction stabilizes for almost 3 to 6 months, you can do, assess how much the residual astigmatism is, and then do a PRK extra in these kind of cases. ICL in suspicious topography, I think the refraction should be stable, as Dr. Manpreet said that she did have a case where patient did show changes over a period of 3 to 6 months. Generally, cases of keratoconus or cases of forme fruste generally do not show progression after the age of 28. 99.7% of the cases of keratoconus stabilize by the age of 27 or 28. So if the patient age is more than that, if it's nearing 30 or more, if the patient is in the third decade, shows a stable refractive error for almost 6 months, and have an astigmatism of less than 6 diopters, if the BCVA is better than 20 by 40, and if they have a clear central cornea, I would think that an ICL would definitely be a good surgical procedure to go ahead with. The keratometric value should be less than 52. Any value more than 52 does induce a lot of spherical aberrations, and though you may have a good uncorrected vision, the quality of vision of the patient may not be excellent. In case you are planning a PRK extra after implantation of an ICL, you can probably do a contour vision with a C3R, try to regularize the topography so as to improve the quality of vision as well. The cone has to be central, which is of paramount importance. A decentered cone is basically when the elevation is away from the central 3 mm, or more than 50% of the cone is outside the central 3 mm. And in these cases, again, these spherical aberrations may be too high for the patient to have a good quality vision. So in these cases, we would first do an intracorneal ring segments or an intax to first of all centralize the cone, regularize the surface of the cornea, wait for about 6 months, repeat their pentacams, and then go ahead with an ICL. So basically, cornea is a nowadays the concept has changed. Cornea is a viscoelastic structure. It's very elastic, and so does the structure of the eye. And I personally believe that the world is a better place when people and structures are more elastic. Thank you very much.
Good, Lou. So, yeah.
In fact, last time we did that keratoconus meet in Udupi. That time I had given an idea to Dr. Rohit that let us do something in the cruise, and it was super hit show. But it was in the night actually, served with beer and wine. But afternoon we are not effort to do that also against our this thing. So anyhow, it was like the attendance exactly it was there for 40 people, and it is totally full. I think I thank Rupal madam that she conducted well, because I last moment just 1 week before we requested. Not even a week before I requested madam, because of my tight schedule, also election saying, I told madam, please this time you have to do the session, but she took it on her shoulders, and she did really good job. Thank you. Thanks for every attendance to attend this session.